All right, everybody, we are at the final lecture of the semester. And the final lecture is on inactivity, kind of the opposite of the entire semester. The first slide is showing a concept we've hit on many times throughout the semester. It introduces how the total energy that we use throughout our day is divided between different activities. The largest section of the pie is basal metabolic rate. And this is the section in your notes where you actually get the definition of basal metabolic rate, lowest energy level required to perform all cellular processes at rest. We talked about basal metabolic rate before. I often refer to it as resting metabolic rate, as that has a lower threshold of rules to be recorded. But this is the energy for ventilation, circulation, peristalsis through your GI system, the just the cellular processes that keep cells alive. So the development of neurotransmitters and the pumping of ions across membranes. That is the energy of basal metabolic rate. Basal metabolic rate takes about 60 to 75% of our total energy expenditure. The other items in the pie, TEF stands for thermal effects of food, and that is actually the energy of digestion. So peristalsis, or the movement, the smooth muscle waves of contraction that go through our intestinal tract, are included in basal metabolic rate, but the active digestion of food, it gets its own separate pie because you can actually calculate that piece out based on how much you eat. NEAT stands for non-exercise activity thermogenesis. Non-exercise activity thermogenesis. Basically, this is all of the energy that is expended on physical activity that is not exercise. Every time you are standing, you are using more energy than when you're completely at rest, like this little dude on the slide is. Walking around the room, a lot of our ADLs really fall into non-exercise activity thermogenesis. And then, of course, the piece of the pie we spent most of the semester talking about is exercise. So let's just go into a little more detail on this basal metabolic rate, since it is 3/4 of our total energy expenditure. It is expressed as kilocalories per hour per day. And the term kilocal is the amount of energy required to raise 1 kilogram of water by 1 degree Celsius. That's how it is the unit for a measurement of energy. Because basal metabolic rate is such a large proportion of our total energy expenditure in a day, when you are looking at someone's total energy usage and when you're looking at their weight loss goals, it can be helpful to calculate their basal metabolic rate. So a very easy method is to just take their body weight times a BMR standard for their sex. Basically, men is just their body weight and women is times 0.9. It's not very accurate, but it gives you kind of a ballpark. The Harris-Benedict equation is the one that would be used in the medical setting, and it takes into account someone's weight, their height, and their age. So this is obviously a much better method. You do not have to memorize these equations. You should be able to plug and chug if given this information, but it's more that I want you to appreciate that you can extrapolate someone's estimated basal metabolic rate in a fairly accurate way if you use their height, their weight, and their age. This energy level required for all of the cellular processes at rest is influenced by what's happening in the body. And we see a lot of things that people might be coming to physical therapists for affecting basal metabolic rate. You can see that when the body is fighting something or healing from something, it's going to raise their metabolic rate. So fever and infection, any wound healing, all of our traumas, our basal metabolic rate generally goes down as we age, and up with pregnancy, and then certain medications can affect basal metabolic rate. This is an important thing to keep in the background of your mind when you're treating patients who might be suffering from a trauma or having multiple wounds or an infection, or a pregnant patient. That's a little bit more obvious, but these factors that change the basal metabolic rate in the background are raising the overall energy demand of the body. So if the individual isn't making changes on what they're taking in, it's going to change their body mass. So it can be an important piece to keep in mind and talk to patients about. You can adjust their BMR if you start with these prediction equations. Then you can use what's called an injury factor to see how the injury might be impacting their basal metabolic rate. So you take the Harris-Benedict equation and you find what would be their typical or estimated BMR, and then you just multiply that by an injury factor. So let's say they had, a minor surgery. It might just be slightly above their predicted BMR. Skeletal trauma might rank it up a little bit. So you can kind of get a feel for how much more energy the body is requiring just for all those kind of hidden processes behind the scene. And since BMR is 60 to 75% of our total energy expenditure, this can be a significant change when something has affected BMR. To appreciate someone's total energy expenditure, you want to take into account their BMR, again calculated from that Harris-Benedict equation. You can calculate the thermal effect of food by taking 10% of their total caloric intake from food, roughly estimates to the thermal effect of digestion. And then there are numbers that have been associated with different levels of physical activity. You can see a very sedentary lifestyle down to someone who has more vigorous activity in their life. And you can add that into the total energy expenditure of the day. So to incorporate physical activity, you take their BMR and you multiply it by that factor to give you an estimate of the contribution of their physical activity to their total energy expenditure of the day. So when we're talking about physical activity as part of your daily energy expenditure, how much exercise do you need? How many minutes per week of exercise is recommended? I'm hoping that in this final lecture of the semester, you can answer that question, being at a minimum, you want 150 minutes per week of moderate to vigorous activity. And normally I do this all together in class, but we kind of take just a few minutes to bring it all together and talk about what we get from that exercise. See how many things do you have in your head now at the end of the semester that somebody who goes from exercise, what do they gain after they go through acute exercise, training? What does exercise give us? If you want to challenge yourself, pause the video and see how many benefits of exercise you can list out, and then we'll go through it together here. All right, so we'll go through them together here. These could be in any order. I'm not putting them ranked in any way. Historically, one of the first ones that comes up is that exercise can decrease the risk of diabetes. I think largely because it's the most recent one we talk about at this time. So you decrease the risk of diabetes, or you could manage plasma glucose if they already have diabetes. So how does exercise decrease your risk of diabetes? Well, you increase cellular uptake of glucose. You increase the number of glucose transporters. You increase muscle sensitivity to insulin, so they're more likely to respond to insulin, all benefits of exercise. Let's see, what else would you have on your list here for benefits of exercise? This can help you to manage weight. So important for weight loss goals, for maintenance of healthy weight. We didn't talk about it too much in this semester, but I think we hit it in pathophys. Exercise can reduce cholesterol. Exercise can decrease the risk of cardiovascular disease. How does it do that? How do we decrease the risk of cardiovascular disease? Well, exercise is going to increase the size of coronary arteries. It's going to increase the size of the heart in a healthy way. It can reduce heart rate. The heart doesn't have to work as hard. If hypertensive, it can lower blood pressure as well. So we're decreasing the risk of cardiovascular disease. We kind of just hit on this very briefly. Decrease the risk of certain types of cancer. It can improve mental health. One I'm just going to add at the bottom, we're going to talk about it today. We can improve or maintain bone mineral density. So when looking at this list, there's some commonalities between the mechanisms behind decreasing the risk of cancer. There's commonalities in the mechanism that decrease cardiovascular disease, that decrease the risk of diabetes. And one piece of this that we haven't yet really talked about is that exercise is anti-inflammatory. And what I mean by that is there are things in our body that cause inflammation, circulating inflammatory cytokines. We talked about this a bit in pathophys with central obesity, and the type of fat that's there releases more inflammatory cytokines. But when there's more systemic inflammation, that can actually be a cause of diabetes. And higher amounts of circulating pro-inflammatory cytokines are associated with cardiovascular disease and increased risk of MI. And a lot of the data showing a relationship between kind of the benefits of exercise in cancer is related to the types of cancer that have increased risk profiles when there's a high degree of inflammatory cytokines. So exercise is anti-inflammatory. And part of that can be seen in this figure. So when you exercise, your brain sends a sympathetic signal out, and specifically the adrenal gland increases the release of epinephrine and cortisol. Epinephrine and cortisol reduce the production of TNF-alpha, a key inflammatory cytokine. When skeletal muscle contracts, it releases interleukin 6, IL-6. Interleukin 6 is an important cytokine that stimulates the production of anti-inflammatory cytokines. So IL-6 helps to coordinate an anti-inflammatory response. Finally, fat cells release pro-inflammatory cytokines. If you can reduce your total fat mass, you will reduce the amount of circulating inflammatory cytokines. So it didn't really fit in places earlier in the lecture, but I don't want to leave you without this piece, because the research on systemic low-grade inflammation and so many diseases, it's starting to feel like this common thread that's kind of woven between all these different very complicated fabrics. So I think over the course of your careers, you're going to hear a lot more about this piece of the puzzle, and we'll learn a lot more about it. There is this balance in our physiology between anti-inflammatory cytokines and pro-inflammatory cytokines. So when you start to get into this literature, it can get pretty complicated fast, because you will see that exercise actually causes the release of both pro and anti-inflammatory. But even though both can get released during exercise, there's so much more anti-inflammatory cytokines released. So the overall effect on the body, if you do like a sum total, like you made like a math equation, the sum total of the exercise response is anti-inflammatory. And this could really be potentially the common thread of why exercise seems to be so helpful in so many different areas, is its role in inflammation. So because all of this great stuff that exercise gives us on our overall health, as well as just human performance, basically the study of people who exercise compared to people who don't exercise is the study of exercise physiology. What do people who have regular exercise look like and have in their health profile compared to those who are deficient in exercise? So there's tons of exercise physiology studies, and a lot of the data that's been presented to you over the course of this semester is you take someone who's exercise deficient and you train them with exercise, and you see how they change, how their lungs change or don't change, how their heart changes, how their blood vessels change, how their muscles change. And we get an appreciation of what exercise does to our physiology. This final lecture is kind of about the reverse. It's about when the exercise isn't there. And the name for this would be detraining. If you take a trained person, basically if you start here and you go the other way and you take the exercise away, you detrain. And so detraining is what happens to your body when you stop exercising. And there is evidence to show that if you take a trained athlete and put them on complete bed rest, they will lose 1% of their VO2 max per day. That is both very disheartening because it goes away so fast, and also, pretty amazing about our physiology. Our body responds to the load that it's given. And when you take that load, that strain, that demand away, your body will adjust very, very quickly. So how does VO2 max go down? Well, VO2 max is meant to represent the functional capacity of the system, the total volume of oxygen you can take in and use. So if this is going down, it must be all the systems in the body that use and move oxygen are being affected. The data from this graph took 7 highly trained runners or cyclists who were exercising for at least 5 days a week for 60 minutes at a time at a moderate to vigorous intensity, and they had them stop. These individuals had sedentary jobs, and they walked less than 500 meters per day. And they observed what happened to their physiological parameters. So if we first look at just day 12 of taking their training away, you see almost a 7% drop in their VO2 max. And if you look at the parameters that contributed, there is this huge drop in stroke volume, like more than 10% drop in stroke volume. So at this point, the AVO2 difference really has not changed, but the drop in VO2 max seems to be driven by the changes in stroke volume that have then affected cardiac output. So by 1 to 2 weeks, there is a significant reduction in stroke volume and cardiac output that is driving the drop in VO2 max. Once you go out to about the 3-month mark, you can see a 16% drop in VO2 max. And now we've really lost the benefit of the AVO2 difference that is contributing to the total VO2 max drop. So most training improvements that you gain from your exercise prescription are lost within several months. This slide should hopefully demonstrate and show that maintenance programs are critical to maintain gains. If you stop, your body, the training effects will go away. To gain insight on the mechanism by which the AVO2 difference dropped, they did biopsies from these individuals, and they saw huge reductions in aerobic respiration enzymes. So the enzymes involved in the use of oxygen in the mitochondria, and then rarefaction, or a decreased number of capillaries in the muscle. These training effects are reversible. While that slide is informative and slightly terrifying, it's also not typically what we're looking at in the clinic. The average American is not normally detraining from some elite training program and losing some beautiful physiological structure that they're starting with, but rather they are sedentary at baseline. Only 28% of Americans meet the exercise recommendation requirements. 28% of Americans. And if you look at minority groups and less educated, the number gets much lower. It's about half that. So most people are not detraining, they are sedentary. Obese individuals sit for 2 hours more per day than lean controls. 2 hours more per day of sitting. If you look at the difference between sitting versus standing with very slow ambulation, that is a 2.5-fold increase in energy expenditure. Just getting up and standing against gravity. So where exercise physiology describes the difference between a regular exercise and someone who's exercise deficient, we are typically not just talking about somebody who is missing exercise, but rather somebody who's missing that non-exercise activity thermogenesis. These people are sitting, not just not exercising. 90% of all calories expended from physical activity come from non-exercise activity, standing, a non-exercise ambulation. This is the bulk of the energy expenditure, is all the movements of our day. This graph is created from data collected on 13,344 middle-aged men and women. And they looked at mortality related to their fitness. What's of note is that the center of this graph says average individual. The average individual is not exercising. So if you take this data point and compare it to those who are the most fit and the most active, this is exercise physiology. This is what exercise gives us. because the average individual isn't currently exercising. And if you add in exercise, you can lower mortality. What is happening to the left of this figure? The left of this figure is increasing sitting, the loss of non-exercise activity thermogenesis. So you take people who already aren't exercising, but you have them sit a lot more, and trends show increased type 2 diabetes, increased cardiovascular disease due to increased sedentary behavior. So the physiology of inactivity is not a trained athlete losing their edge, but rather the increased risk of disease that comes from all of this sitting. This is data from a really interesting study, and the measurement that they're looking at is the relative incidence of myocardial infarction. And the two groups they studied were bus drivers and conductors. So they're a similar population. Bus drivers, though, sat without interruption for more than 5.5 hours on their shift. That's the drivers. Conductors have to stand for the same period of time. They maybe have some slow ambulation waiting for the bus or stabilizing themselves on against a moving vehicle, but in general they stand. So the difference between these two groups is one has more sitting than the other. Just increasing the amount of sitting created a 2-fold higher risk of myocardial infarction. So physiology of inactivity isn't simply the removal of exercise, but the loss of physical activity throughout the day. Studies have shown that for each hour of TV per day, there is a 20% increase in prevalence of metabolic syndrome. And very important in our world, the highest risk profile is when someone is on total bed rest. Many of the patients we see are in extreme activity deprivation. So the data from the next part of this talk will really all be coming from inactivity studies, but most of those studies use a bed rest model or a anti-gravity. There's a lot of studies that have been done on the space station where gravity is eliminated. So these studies are easy to perform because you can take a person and put them in the bed and see what happens. But they definitely have some limitations because laying supine might have different effects than sitting even. It might be, it's probably a more severe form of inactivity. So I will present this data as the physiology of inactivity, but please know where it comes from. It comes from mainly bed rest studies or anti-gravity, which might be a slightly more severe form of inactivity. But hopefully these early slides show or express how physiology of inactivity is a severe thing. Increasing sitting is creating an extreme environment that's promoting disease and metabolic disease. Okay, so these now are the kind of knowledge that we have gained from these studies, and we'll go through the physiologic effects of inactivity. They're summarized here on this picture between metabolic reactions like response to insulin sensitivity, exercise capacity, the heart, the blood vessels, and skeletal muscle. Let's start first with skeletal muscle. Inactivity causes skeletal muscle atrophy. Again, atrophy is a decrease in mass and cross-sectional area, and it's usually in response to a reduction in physical activity. So as you can see in your notes, atrophy can be caused from hypokinesia or decreased movement, and or hypodynamia, which is decreased mechanical load. So skeletal muscle is made out of protein, and protein is a highly dynamic tissue in our body. We are always breaking down and building. And the balance of which one of those two dominates will affect your overall muscle mass. Exercise, as you guys know, stimulates protein synthesis. If you stop exercise or you decrease either mobility or load on the muscle, you're taking away this stimulation and you will decrease total protein synthesis. So inactivity does not stimulate degradation. You don't get more degradation with inactivity. You get the same amount of degradation, but you lose the new synthesis. There have been studies that have shown the loss of protein synthesis occurring within 6 hours of casting. So 6 hours of immobilization, and you already see a reduction in protein synthesis. This slide that you're looking at is the calf muscle before and after 90 days of bed rest. And you can see that total immobilization has a dramatic effect on muscle mass. And the data that's in your notes is you see a 3 to 4% loss of protein per day. I like mentioning the next piece in your notes on this slide because you can physically see that the calf has gotten smaller. And reminder that cross-sectional area parallels force capacity. There are many things that contribute to the overall force output of a muscle, but the total number of cross bridges is a significant component of that. If you reduce the myofibrillar protein in a muscle cell, there will be fewer cross bridges. Fewer cross bridges mean less force. This is data that was collected from astronauts that were on a 17-day mission, and we're looking at that effect on force. And you see that pre-flight compared to post-flight, there is a significant drop in peak force. Strength goes down. This study showed also that power goes down as well. I'm just showing you the peak force data. And this is from the same paper. They did a recreation of what the sarcomeres looked like before and after the 17-day flight. So you can see the thick filament in the middle should be paralleled on either side by thin filaments. After the space flight, there's significant atrophy, and you can see loss of thin filaments, kind of shortened loss of these thin filaments, which will decrease the total cross bridges available in this muscle, and it translates to a reduced total force production. So with a lack of movement and a lack of mechanical load, you will have physical atrophy and loss of protein in skeletal muscle. Skeletal muscles will get weaker. The positive of the adaptation in skeletal muscle to strength training was how quick we can see an increased force because we have those neural adaptations. Well, inactivity is going to also alter the neural response. And with inactivity, you see reduced conduction velocity. The signal will not get there as fast. Reduced motor coordination, activating the right set of motor units for the task that you're asking for. To have the most efficient activation of the muscle is lost with inactivity. And then you see poor electromechanical coupling. The transmission of that electrical signal from the nerve actually creating the mechanical response in the muscle. Let's move on to the cardiovascular system. And I put these two images on a slide to tell a story. The cardiovascular system is this complicated web of blood vessels that hold liquid in tubes, obviously pumped throughout the body by our central pump, our heart. but it really is liquid in tubes. So when you are standing up against gravity, you have a lot more liquid in your feet, right? Those compliant veins stretch and are able to take that volume less as you go up. You actually have to drive the blood up against gravity to get into your brain. What about this dude here, who is given this wonderful educational opportunity of staring at a screen? I will try not to get on my soapbox about that. It's helpful to not have a live audience because sometimes I can't resist when you guys are in front of me, but I'll resist now. All right, where's his fluid? Laying on the couch, doing something inactive. What is the gravitational effect on fluid here? The fluid is going to be spread out throughout the body, which means receptors in your carotid bodies, your aortic arch, within your heart, that sense that increased volume are going to stimulate natriuresis and diuresis, and you're actually going to reduce your total plasma volume. So this standing up and allowing a lot of volume to hang out in our veins and in our lower extremities allows us to have the volume necessary when we need to have the larger distribution like we used in exercise. But the more time you spend supine, you actually reduce your total plasma volume. Let's walk this through and how this would affect the cardiovascular system. Let's imagine this is the monitor from a patient who had a motor vehicle accident. They are healthy, no heart problems, no lung problems, a few broken bones, but now they've been laying in bed. And what do we expect to see? I wouldn't expect a big change in resting blood pressure. Our body is very good at regulating blood pressure. As they lay here, their fluid is being distributed throughout the body, and they've likely gone through diuresis and natriuresis, and they have a lower plasma volume. You show up as the PT, and you say, let's get out of bed. What do you suppose will happen? Well, she had a resting heart rate of 65, and it shoots up to 80. That's a big jump just going upright. What in the heck happened here? With less volume, she has less venous return. Less venous return means smaller stroke volume. How is she managing to compensate for this gravitational stress? She's using heart rate. She's using heart rate to maintain cardiac output and pump up against this new gravitational stress, which is exactly what we see here. As you increase exercise intensity after bed rest, you see an exaggerated heart rate response because of the loss in stroke volume, because of the loss in plasma volume. So the longer someone's in bed, the more you expect an exaggerated heart rate response when they go to move for the first time. This is a huge reason why we try to get in there as early as possible. As soon as they are medically stable, get them up and get them against gravity. Because the longer they lay, they lose that volume. And what is this person with the open circles experiencing? Higher myocardial demand. So if there was any underlying cardiovascular disease here, we are asking more of their heart now because they're making up their cardiac output with heart rate because they don't have the volume. What is the other thing we notice that happens to this patient's vitals? Their resting blood pressure was 110/80. Just getting them up against gravity, their blood pressure plummets to 100/67. If you turn to the next page of your notes, this is where you had some space to talk about that thoracocephalic shift. The pressure gradients that have changed from when this person was standing up against gravity and blood was pooling at the bottom at higher pressures versus their bed rest time where blood was distributed throughout and your body ends up getting rid of that fluid because the sensors up at the top are experiencing a higher than normal amount of fluid. So the body says, get rid of this volume, and you pee it out. And then what happens when you get them out of bed for the first time? So this is an image that shows orthostatic hypotension that occurs in astronauts, but it works the same with someone who's been in bed for a while. When they were pre-bed rest, earthbound, normal conditions, we have, as illustrated by the red coloring on this picture, a lot more blood that pools in our feet. When they laid in the bed for however long they have been unable to get up against gravity, they removed the volume. They slowly have diuresis and natriuresis and remove their total blood volume because of sensors that have detected this higher amount of fluid coming back to the central system. Now we show up and say, hey, PT has been ordered. Let's get you up and get you out of bed. And they stand up and they don't have the volume to let a bunch of fluid fall to their feet and still maintain appropriate pressures at the top. There's not enough volume to make it up to their brain, even with the normal vasoconstriction and increased cardiovascular response that you would have upon standing. And they experienced orthostatic hypotension. They can't maintain their blood pressures against gravity because they don't have enough volume to vasoconstrict it back up. What is the message here? One, it's important to know the expected abnormal responses. If you're going to get someone moving who hasn't moved in a while, that you might expect exaggerated heart rate responses and initial orthostatic hypotension, but also the importance of getting patients up against gravity as soon as possible to keep their pressures and keep that gravitational strain on their physiology. This loss of fluid affects the heart as well. And in response to inactivity, we do see reductions in cardiac size. Specifically, the volume plays a key role here because with less volume getting back to the heart, you get less stretch of the ventricle. And this ultimately causes a reduction in size that reduces the left ventricular end diastolic volume. Because you're not stretching the heart with a big venous return, the heart gets smaller, which is problematic when you then come and want to begin activity and they have a smaller volume to work with to maintain their cardiac output. The other thing that happens is without exercise, without physiological strain of gravity, having to pump up against that, pump up against the gravitational stress on the circulatory system, the heart isn't working as hard. And you see cardiac muscle atrophy. The atrophy is more than just a loss of stretch from volume. So there's the hypovolemia, but there's also reduced strain on the heart, kind of less overload, and you see atrophy as a result. So the heart gets smaller in volume and it gets weaker. With inactivity, we are worse at delivering oxygen. Inactivity is associated with decreased red cell mass. When you are inactive, there is less erythropoietin release, which means you make fewer red blood cells. We also see vascular rarefaction. That is what's seen up here at the top of the slide. This rich, capillary, dense tissue with so many blood vessels for each muscle cell so that the distance for oxygen diffusion is very small, absolutely goes away with inactivity. Rarefaction is the loss of blood vessels. Look at the distance an oxygen molecule would have to travel on the right-hand side picture compared to the left. When we see that drop in VO2 max in the detraining studies, you can see how the periphery has gotten worse at its use and delivery of oxygen because there are fewer red blood cells and there is fewer capillaries, which increases the distance for oxygen diffusion. Because all of these systems are interrelated, the effect of physical inactivity is a reduced exercise capacity. Weaker, smaller muscles that are worse at using oxygen. A reduction in stroke volume, which means you have a reduction in the maximum cardiac output. And along the way, in those submax ranges, the cardiac output is being maintained with heart rate, which is a greater load on the heart. Reduced hemoglobin, reduced capillarization, and reduced skeletal muscle blood flow is all going to come together to make us worse at taking in and using oxygen, which will lower exercise capacity. If you look at the endocrine response of inactivity, we see a reduced sensitivity to insulin. This is specifically the most severe in active muscle. So after 5 days of bed rest, they did a glucose tolerance test where they gave a load of glucose to see how well the system could clear the glucose out. A reduced sensitivity of insulin tells you that you need more insulin to get the job done. You need increased insulin release to clear the same amount of a glucose load because the cells are no longer responding as robustly to that insulin signal. The magnitude of insulin resistance is related to duration. So the longer somebody is on bed rest, the worse the insulin resistance. This is going to put so many of our patient populations at risk for diabetes. Inactivity makes an environment where cells are less reactive to insulin. Specifically, we see a reduced number of GLUT4 receptors. So if you remember, cardiac, skeletal, and fat require these GLUT4 transporters, which live in the cytosol and have to be directed into the membrane for glucose uptake. There have been bed rest studies that have shown reduced numbers of GLUT4 transporters after 6 days of bed rests. There have been studies that show changes in GLUT4 numbers after just 24 hours in a cast. Highly dynamic tissue. In those studies that looked at casting related to GLUT4, if the subjects did isometric contractions, they could totally prevent the loss of GLUT4 transporters. So sometimes we can't avoid the inactivity, but we can make the best of the situation if we know the physiological response and take steps to try to prevent it. And then obviously, this is reversible with activity. If you can get the cast off, if you can get them out of bed and you can reintroduce activity into their lives, you can replenish the GLUT4 transporters. One interesting piece of this insulin puzzle is insulin is involved in protein synthesis. So when insulin binds to the insulin receptor, one of the downstream effects is to stimulate protein synthesis. So this insulin insensitivity is hypothesized to contribute to skeletal and cardiac muscle atrophy because it is a known stimulus for protein synthesis. The last thing on your notes is that inactivity is pro-inflammatory. So with inactivity, we see a greater proportion of the cytokines being pro-inflammatory cytokines. So obviously, a greater fat mass has a greater pro-inflammatory profile, but without even the time it takes to change total fat mass, inactivity itself is associated with higher levels of pro-inflammatory cytokines. For our kind of average American profile, the picture we're kind of trying to paint here, the another stimulant to pro-inflammatory cytokines is a high caloric diet. A high caloric diet is pro-inflammatory as well. So if you add that into that picture of inactivity, you can start to see this perfect storm of systemic inflammation. So this last piece is the part we have basically ignored up to this point, and that's the fact that all this muscle is attached to bone and what we are doing to and for bone with and without exercise. So I will end the video at this point in the lecture and finish the bone in a separate series to stick to these shorter time frames. Take care.